COVID has made each one of us an expert here when it comes to Zoom.
Ma'am, we are live in 3, 2, 1. We are live now.
Hello, everyone. Welcome. I'm Dr. Sayyada Rashida. I'm a psychiatrist and I'm based here in Mumbai, India. And I'm passionate about women in psychiatry and women leaders in psychiatry. And a lot of us are doing such amazing work. So we thought, along with Intas Pharmaceutical, that it's high time we bring a lot of these leaders and speakers out front and let them not shy away from shining their light bright and wide. Did not mean to rhyme. So here you go. That's how excited I am that it could make me a rhymer as well. So welcome. This is hopefully a beginning of a very special curated series where we are going to come up with topics that are more relevant maybe to women's mental health and perinatal psychiatry, also highlighting women leaders in the particular field, both in clinical research and in other fields. And hopefully we do attract a lot of not only just women attendees, but also men, because yes, men mental health professionals also deal with women patients and clients all the time. So without further ado, we had the series had to kick off with none other than Dr. Sonia Pariyal. What do I say about Dr. Sonia Pariyal? That all of us, especially in women's mental health and perinatal in India, don't know that. Don't know her. She owns a space like no one else can. She's a senior psychiatrist from Raipur, primarily in private practice, but hugely academically oriented, and such a huge support and mentor and a teacher for all of us, age no bar, gender no bar, and topic no bar for that matter, and has a sweet personality and has a sweet disposition. So one can imagine her bedside manner alone might be so curative and therapeutic to a lot of her patients. She has a lot of credentials academically, has written clinical guidelines, chapters, and published articles in national and international journals, primarily around women's mental health and perinatal as well. So of course, today the topic that we have is also very close to her heart. And when she also suggested, and I jumped on it because I think this is one of the most interesting things we need to start looking at. The topic for today is reproductive depression. Is that a subtype of depression? It's a very interesting field, and I think the more we find out about it, the less we know. We all know the position and the power estrogen has in terms of development, but it also in terms of learning and cognition. And we also know that women have these unique depressive episodes and symptoms and syndromes, which we of course know is so interconnected to the reproductive and the metabolic cycles as well. So shedding a little bit light on this topic is our very own favorite and deared and beloved and revered Dr. Sonia Pariyal. Dr. Pariyal, I welcome you on board, ma'am, and we are all looking forward to hearing from you. And of course, after that, we'll have this panel of wonderful and amazing women bringing clinical pearls to the discussion. So over to you, ma'am.
Good evening, everybody. So it's so nice to have you all on board on a very important area, that is reproductive depression, a subtype. Now, I think there are a lot of endocrinologists and obstetricians who had a keen observation, rather than the psychiatrists, that PMS and postpartum depression and menopausal depression, they are a different type of depression with hormonal etiology. And they felt, especially Craig et al., a seminal paper, by Craig et al., he mentioned that psychiatrists are using SSRIs and antidepressants for these disorders, but there can be an hormonal treatment possible for these disorders because they felt that these subtypes have a prominent hormonal etiology. And it was Craig and then Studd et al. These are two people, I think, who started writing in this area a lot. And as psychiatrists, we know in clinical practice, we are quite scared to use hormones, and we'll come on to it why, because of the risk of side effects, especially the WHI study, if you know, when it started, it created a lot of hue and cry about side effects. But when this study was evaluated, it realized the kind of fear that it created, that study was not very well adjusted with the clinical implications that it indicated. And it was realized that the estrogen supplements that we're using can be much safer than what it was thought to be. Anyway, we'll go more into detail of that later, but let's begin with, is reproductive depression really a subtype, or is it a part of the major depressive spectrum? So when did just get onto my slides are not moving. Just a second. Now we know that major depressive disorder is twice as common in women than men. And these gender differences, they emerge more at puberty, with nearly 14 to 33% of depressed women enclosed by the fifth decade, corresponding to the women's reproductive years. That means there's a double incidence of depression in the reproductive years, indicating that there is probably a role of hormones in this duration of reproductive cycle. And there are a subgroup of women who are more susceptible to hormonal fluctuations during the reproductive transitional state. And these reproductive transitional stages, they can affect the hormone-sensitive brain areas which are involved in emotional regulation in the vulnerable women, which means that there's a change in hormone, it can directly affect the hormone-sensitive brain areas which are involved in emotional regulation. This is the very important aspect of understanding reproductive depression. Now, if you see within the reproductive life cycle, the time periods associated with hormonal change are known to precipitate mood symptoms in a subgroup of women. Like, for example, what is the early transition? It is during the puberty, following the onset of menarche. Then you have the very fluctuating period of hormones during the premenstrual dysphoric disorder phase, the premenstrual phase. During the menstrual cycle, you see a significant amount of mood fluctuations, which are now being called as PMS and PMDD. And the third is the postpartum depressive disorder, that is, and the perimenopausal depression. So in all these four identities that have been labeled as subtypes, you can see a significant fluctuation in the hormonal changes. So what is reproductive related disorder? It has been hypothesized as an effective vulnerability to hormonal change and as a specific biological response to hormonal fluctuation in the brain that leads to depression that occurs during the women's reproductive life. More precisely, it is positioned as reflecting the effects of drastically changing levels of estradiol and progesterone during the premenstrual, postpartum, and perimenopausal phases. A growing body of literature has demonstrated that estrogen's modulatory effect on the central nervous system, especially the serotonergic system in the brain, is responsible for these changes. Now, other than estrogen, now we have also noticed that progesterone and its metabolites, they are also having a significant impact on the central nervous system, which we all need to be aware of. Now, what are the evidence to support that these four stages are reflecting different biotypes? The lines of evidence that support the idea are correlation between reproductive depressions at different stages of reproductive life, then genetic studies, evidence that the risk of depression is elevated for women during times of hormonal change and decreased during times of hormonal stability. Like, post-menopause, the incidence of depression in male and female comes to nearly the same. Similarly, in the antenatal period, we have seen when in pregnancy, when the hormones, estrogen levels are not that fluctuating, the incidence of depression is lesser compared to PPD. So correlation studies have demonstrated that depression occurring at different stages are probably associated with each other. A number of studies have shown that history of one type of reproductive depression predicts depressive episodes at other times of hormonal change. For example, say if a lady has PMS, the chance that she may have PPD is higher. Similarly, if there's history of PMS, there is a chance that she may have a higher incidence of perimenopausal depression. So these three disorders, PMS, PPD, and perimenopausal depression, may be reflecting separate biotypes of depression rather than they being part of MDD. So there are a number of correlation studies that have been very beautifully highlighted in the review article by Payne. Because of paucity of time, I'm not going into it, but I think we all can get a message that a lady who has PMS or PPD or both may have higher incidence of postmenopausal depression as well. Now, what are the genetic studies which are giving us hints that these are different biotypes of depression? Several analyses of heritability of premenstrual symptoms as well as twin studies suggest that premenstrual depression may have a genetic basis. Similarly, PPD also exhibits familial aggregation in families with MDD, suggesting a genetic basis. In fact, what they found was that in families with MDD, PPD clusters in some, but not in all families, supporting the idea that the vulnerability to PPD is separate from the vulnerability to major depressive disorder. There are now studies that suppose that there's a past history of PPD. There is a higher incidence of this lady getting PPD in her second pregnancy also. And if there's a family history of PPD, suppose her mother has an episode of PPD, the chances that she can also have a higher incidence of risk of developing PPD, which means that this could reflect a different biotype. Familial aggregation among women with PPD was seen only when PPD was developing within 4 weeks of delivery. This is a very important part. The first 4 months, if you see the definition of postpartum depression, many researchers have extended it to 1 year as well. But the hormonal trigger is usually in the first 4 weeks. That is the rapid withdrawal of estrogen and the fluctuation of the downfall or withdrawal of estrogen and progesterone is in the first 4 weeks. So PPD, if seen in the first 4 weeks, it indicates that there is explains the critical window period hypothesis, which means the rapid fluctuation, rapid withdrawal of estrogen and progesterone during this time, maybe this is the hormonal trigger, which is reflecting a different biotype. Now, it has been seen when hormone levels are not fluctuation, like I had mentioned during pregnancy and post-menopause, the risk for depression does not appear to be elevated. While the rate of MDD is well known to double the rate in men during reproductive years when hormones fluctuate, indicating that during hormonal stability, probably if there is depression, it is more due to MDD rather than these different biotypes like PPD. Depressive symptoms, they also increase during transition to menopause. But we know in the later part of the post-menopausal part, depressive symptoms are not seen that much. And in this period, it was Freeman et al. Who had a very interesting observation that the hormonal change during the perimenopause, there is a higher risk of mood fluctuations. And as the menopause settles, the incidence of depression is not seen that high, supporting that there is a hormonal element in the perimenopause period, which will respond to hormonal interventions better. So what are the potential mechanisms of reproductive depression? These are all hypotheses, but they give us very important clues in understanding the subtype reproductive depression. It has been hypothesized that women with reproductive related depression have abnormalities basically within the gonadal steroid system. Multiple studies have also shown that hormonal levels of estrogen and progesterone are normal in women with PMDD, PPD, and perimenopause. But what is the level is normal, but the change is the one, the fluctuation of these two hormones when they occur in these periods of PMDD, PPD, they are crucial to manifest the disorder. So therefore, research was very difficult, in this time, because we could not show that there are low levels every time of hormones during these periods. And how do you go about comparing it with MDD? To prove the hypothesis that estrogen is low or progesterone is low, and that's why you're manifesting this disorder. What interestingly was found was that each of these women are differentially sensitive to the hormonal change. And every system which is implicated in depression, in the neuromyological model of depression or the other etiological causes of major depressive disorder, the three systems that were implicated were neurotransmitter deficiency, neuroplasticity deficiency, and network abnormality. And interestingly, estrogen seems to affect work at all these three levels. So if there are fluctuations in this hormone, there will, during these reproductive subtype change periods, you will experience neurotransmitter deficiency, neuroplasticity deficiency, and network abnormality, which is modulated by estradiol and as well as progesterone and its metabolites, indicating that we need to study this impact of these neurosteroid hormones on the central nervous system, especially the brain circuitry. We will go about each of these in my coming slides. First, let's discuss neurotransmitter deficiency. The synthetic and metabolic enzymes and receptors for all classical neurotransmitters, right from serotonin to dopamine to glutamine, are regulated by estradiol. It has been proven. Now, the estrogen 2' neurons to respond more efficiently to stimuli through regulations of brain's major excitatory neurotransmitter, that is glutamate. Now, estrogen has two types of estrogen receptors, estrogen receptor alpha and beta, which are present in the central nervous system, especially in the brain. And estradiol can activate the metatropic glutamate receptors, even in absence of glutamate, and increase synaptic trafficking of at least one type of ionotropic, that is ion channel containing glutamate receptor, and the AMP receptor. So estrogen modulates glutamate in the brain. And it also promotes neuronal survival and decreases oxidative stress. It also improves neuronal energetics by increasing mitochondrial efficiency. It has also been found to increase both dendritic spine density and synaptic plasticity, and increase cell in response to a variety of toxic insults like hypoxia, inflammation, excessive glutamate, and decreased glucose. So now you know that in major depressive disorder, we have implicated neuroplasticity as a very important factor in causing depression. So if these hormones fluctuate in the different periods of PMDD, PPD, and menopause, the change of estradiol can affect all these functions. Now we know the neurobiological model of depression, especially MDD. The basic function that was implicated was that there is a network abnormality present in the neuronal networks. That is, these networks are structurally and dynamically connected brain regions with coordinated activity enabling effective and efficient response to the environment. The most important networks are the default mode network, the social cognitive network, reward network, affective regulation network, and the central executive network. Evidence exists that there is dysfunction of each of these networks in depression. But in the subtypes of depression, the reproductive type of depression, what they have found is probably there are different areas affected. For example, in PPD, default mode network was highlighted more, in addition to effective regulation network. So scientists are now researching that what are the networks which are more implicated in MDD and which are the networks implicated in these subtypes. So this is still in research area, but this is an interesting way for us to identify that these probably the reproductive subtypes, that is PMDD, PPD, and perimenopause depression, they may have different network abnormalities compared to the network abnormality in major depressive disorder. Now let's look at a very different aspect which gives us clue that there is a different biotype involved of depression existing in the role of reproductive steroids in affective illness. A very interesting study done by Schmidt et al. Right in the early years of 1998, where what he did was he took 10 women with PMDD experiencing a recurrence of mood symptoms when estrogen or progesterone was added back after symptoms were stabilized by GnRH hormone analog, gonadotrophin releasing hormone analog, liopride. Now, if I go back to the slide, if you see when lioprolide, which is a GnRH analog, you see in a normal lady with no history of PMS, there are no change in mood. And if you induce a fluctuation by giving estradiol in addition to lioprolide or progesterone, again, there is no mood change noticed. Whereas if there is a history of, you take females with PMS, Leupride, it suppresses ovulation. Mood fluctuations are decreased. But when you add back with estrogen and leupride, you're seeing sudden change of mood in the 3rd week when estradiol is given, and in the 2nd week when progesterone was given with leupride. That means when you are inducing a fluctuation due to adding estradiol with leupride or progesterone with leupride, you're inducing a fluctuation of the hormone, you are seeing change in mood. But once it is stabilized, the mood improves. So this was a very interesting model to show that if you can stop ovulation and you can induce fluctuation, depressive symptoms are being induced in premenstrual disorder. So it is the change of hormonal level which is leading to affective instability during these periods. Similarly, in PPD, there are studies which have shown that in women with PPD, there is a recurrence of depressive symptoms when high doses of estrogen and progesterone were withdrawn suddenly, modeling the hormonal model of PPD. That means when there is estrogen, sudden withdrawal of estrogen, the lady can have PPD. Now, there are other clinical studies which implicate other systems as well, indicating that they are different biotypes. Sex differences in serotonergic function provide indirect evidence of female-specific hormone influence on the serotonergic system. Like I had mentioned earlier, it has been found that females, they respond better to SSRIs. Why is it so compared to males? This is an area of research going on. It has been found that euthymic women without a history of MDD appear to be at higher risk than men for developing depressive symptoms in response to low level of serotonin compared to their male counterparts. And when they did PET studies in females with PMDD, what they found was that there is a reduction in the 5-HT1A receptor binding in the dorsal raphe nucleus between the follicular and luteal phase relative to normal female controls without PMDD. So interesting area to know that even the receptor binding is poorer in cases of vulnerable women who are prone to PMDD. Now, there are other radiological studies also which provide us evidence. For example, PET studies in women suggest that serotonin receptors implicated in depression are affected by female gonadal hormones and cycles. That means the number of receptors are affected by estrogen and progesterone. Prefrontal region, especially the medial prefrontal cortex in particular, which is also relevant to pubertal depression and adult onset MDD, they found that in these areas, serotonin receptors are lesser. The hypothalamus, the amygdala, the anterior cingulate, orbitofrontal and dorsolateral prefrontal cortices, insula and striatum. These are the most important areas of brain which have been implicated in major depression, and they have also been found to be involved in pathogenesis of postpartum depression. But there is variability of activity in these different areas of brain, which indicated that probably the reproductive subtypes of depression have different areas of brain affected, which could probably give us biomarkers to identify who are the women who may be more prone to PMDD or PPD or perimenopausal depression. Again, one very interesting observation, when studies which have found linked IVF studies of depression, we see so many of our women who are infertile and going for IVF having higher incidence of depression. Now, what they found was that ovarian stimulation protocols based on administration of gonadotrophins and GnRH agonists for inducing the down regulation of GnRH receptors and consequent hypogonadism. When these protocols were used, you induced hypoestrogenism in these women, and they experienced significant mood symptoms, which again gives us a clue that hormones have an important role to play in these different subtypes. Like I had already mentioned, the mood sensitivity to estrogen and progesterone. This is a very important aspect of understanding the etiopathogenesis of reproductive subtype of depression. Not all women are sensitive to fluctuations. There is a subset of women who are sensitive to this fluctuation of the hormone. The ability of sex hormone fluctuations to inflect neuroendocrine circuitries in the female brain is an elegant mechanism to adjust homeostasis in line with demands of reproductive function, which means that whenever there is change in hormones, it is affecting the neuroendocrine circuitries in the brain. Neuroanatomical and functional peculiarities of the female gender predispose the women to specific conditions when brain is challenged by internal or external stimuli, allowing estrogen to have a psychotherapeutic effect in women. So the adaptive responses are at molecular level, cellular level, and system levels, depend on the individual threshold of vulnerability, which is modulated by a complex area of determinants, of which the important are the genetic predisposition and the hormonal change vulnerability which women are experiencing. So such stages of transition like menarche and menopause and the marked fluctuation in the premenstrual or postpartum period exert a profound effect on brain regions, especially related to reproduction and on brain areas which are relevant to the mood, memory, and behavioral and cognitive responses. So how linked is estrogen to various functions of the brain, including mood and reproduction? When estrogen concentrations are low, that is in the postpartum and menopause, or when progesterone concentrations are high, example, premenstrually, when depression occurs in women in PMDD in the luteal phase, it establishes that they reflect a different biotype. Gordon et al. Has some seminal work done, and he did a very recent study founding evidence that both hypo and hyperestrogenism is important in triggering perimenopausal depressive symptoms. This was a very interesting study, which I'll discuss more in detail when we have time. And he found that it's not just the low level of estrogen which creates depressive symptoms. It can also be a higher level of hyperestrogenism, which can cause mood fluctuation. So it is the change which is the important factor which is coming into play. Now, how does the level of hormone affect the neurocircuitry, and how does it affect the central serotonergic activation is a very important area of research, because when it was found, when there's changing fluctuation of hormone, it is affecting the central serotonergic activation as a mechanism, and it is receiving the most attention because it is a potential mediator of negative mood effects of estrogen withdrawal. That means when estrogen is withdrawal, the central serotonergic system is not working well, and deficiency of serotonin, we know, is responsible for mood change. Another very important mechanism of mounting interest in recent years in the etiology of perimenopausal depression and postmenopausal is the fluctuating level of the GABAergic neurosteroid, that is allopregnolone. This is a very important molecule which has come into study recently, which I'll explain to you more. Before that, I would just like to suggest the hypothesis by Gordon that this estrogen sensitivity, 61% of normal, if you see an overall figure, 61% women are not sensitive to change of estrogen hormones. That means that sort of population of women are normal women who do not get affected by estrogen change. That means they will not experience reproductive subtype of depressions. Whereas those with MDD may have depression, but without this estrogen coming as a factor. The change sensitive are the 20%. And there is also 7% which is known to be increasingly sensitive. That is, if estrogen levels are increased also, there is hyperestrogenism also. Some women will experience change. And 20% are change sensitive. 7% are withdrawal sensitive. That is like say in PPD. When it is withdrawn, estrogen is withdrawn, they'll experience depression. And they've also studied the level of change, how it is affecting the scores of depression. For normal women who are not sensitive to estrogen fluctuation, there'll be no change in mood. And if you can see the change sensitive graph, the three in different areas, if there is change, they are experiencing mood fluctuations. And once the change is coming down or stabilizing, then the mood is improving. That means it is the fluctuation or the up and down which is related to the mood change. On basis of this, Gordon has proposed certain E2 sensitivity profiles and hypothesized time course of depressive symptoms. It's a very interesting hypothesis that he has put forth, in which he says if there are women, a subset of women who are sensitive to increase of estrogen sensitivity increase, they will have a history of PMDD. And in early menopause transition, where there is polyovulation taking place, then these women will experience mood change. History of E2 decrease, like I said, if there's history of PPD in the perimenopausal women, they will, if there is history of PPD, they are the ones who will have mood fluctuations in late menopause transition or early post-menopause phase. That means they are estrogen withdrawal sensitive or decrease sensitive. And E2 change sensitive, you know, in PMDD, there is a lot of change in fluctuation of hormone. Similarly, in PPD, there's withdrawal. Then all these three, that is PMDD, PPD, can occur when they are change sensitive. But if they are insensitive, there is no increased relative to the post-menopause period. That means history of mood disorders may be present, but they are not tied to the reproductive events. It's an interesting hypothesis in which research is going on. Now let's take individually premenstrual dysphoric disorder. We know, we have seen in clinical practice that many normal women also experience PMS, but it going on to severe stage has been defined as premenstrual dysphoric disorder. This is happening mostly in the luteal phase of the menstrual cycle. Most women experience physical symptoms, and a significant number will suffer from depression, irritability, and anxiety. And it occurs shortly after ovulation and persists throughout the luteal phase. So if we can, you know, it is occurring only after ovulation. That means when there is a fluctuation of the hormones. So during the course of menstruation, the symptoms become less severe and remit entirely during the subsequent follicular phase. Like you can see in this very interesting diagram, that as the estrogen, the graph of estrogen, if you can see the levels of estrogen and at ovulation are peaking, but after ovulation, they are suddenly dipping and there's increase in progesterone. So during this change, this is the hazard zone, the 21 to 28 days of the cycle. And just immediately, just once the menses are beginning, during this period, there is the maximum change or fluctuation of estrogen and progesterone. And during this time, the women experiences maximum symptoms. Despite the plethora of functional imaging on PMDD, we have not been able to see resting state functional connectivity analysis studies in PMDD, but in PMS they have been done. And what they found, that what I had discussed earlier, that the default mode DMN network is disrupted in women with PMS compared to healthy controls. That means if the default mode network is not working well, the chances are that women will have experienced higher anxiety, stress, and depression scores. Again, in PMDD, the prefrontal cortex and its distinct role was studied. We know even in major depressive disorder, the abnormal function of the prefrontal cortex includes hyperactivation in the medial prefrontal PFC and hypoactivation in the lateral prefrontal cortex at rest. But in PMDD, there is additional abnormality seen in the insula. During the luteal phase, the insula is highly activated in women with PMDD, indicating that it is a different biotype. Now you can see this is a very interesting research done by using fMRI by Stickle et al., where he studied the brain activation patterns in all these areas which are implicated in the neurobiological model of major depressive disorder and compared it with these three reproductive subtypes. If you see in the striatum, there is hypoactivation in puberty depression, in PMDD and PDD. That means this is a trait marker. In the striatum, there is hypoactivation, which is also seen in the neurobiological model of MDD. But in the amygdala, if you notice these dotted lines, blue and red, which indicate that in puberty depression and PMDD, in addition, amygdala hypoactivation is also being seen. Similarly, if you see, there are inconsistent findings about activation in the insula. Insula is again an area which is being studied a lot in PPD, where they found that in when you see puberty depression and PPD, insula is affected, which was not seen that much in MDD. This indicates that if we study through fMRI different patterns of brain activation by giving different tasks, these will help us to identify different subtypes of reproductive depression. So sex steroids are believed to be intimately involved in the etiology of PMDD, and it is not the in women with PMDD, symptoms are not preceded by excess or deficit, but rather by individuals' response to fluctuating levels of sex hormones. And it also been found that exposure to or withdrawal from allopregnol, which is a progesterone metabolite, it may contribute to PMS. Now, allopregnol is a very interesting molecule. It is a downstream neuroactive metabolite of progesterone, and it is active at GABA A receptor. This molecule is being used successfully not only in PMDD, but also in PPD. Allopregnol is expected to exert a calming effect due to its positive modulation on GABA A receptors. It demonstrates a biphasic relationship between negative mood state and blood concentrations. What has been found is at moderate level of allopregnol, you may see a paradoxical anxiogenic effect, whereas at higher or stabilized levels, allopregnol is expected to produce a more anxiolytic effect. So rising allopregnol levels during the luteal phase may contribute to PMS and PMDD. But it can also be used as a therapeutic agent in the PPD phase, which I'll discuss later. Now, interestingly, if you see progesterone, like I had mentioned, is metabolized to allopregnol, and SSRIs, they help in the conversion of dihydroxyprogesterone to allopregnol, which means that, and allopregnol attaches to GABA receptors. It has a calming effect. So SSRIs, they are not only improving the levels of allopregnol, but hence indirectly improving mood by other than its original action of improving serotonin levels. That means they act by improving serotonin levels also, and also improve allopregnol levels. And maybe that is why SSRIs are appearing to work better in these reproductive phenotypes, that is PMDD, PPD. So this, like I'd already mentioned, that SSRIs may through a primary increase in serotonin in addition to allopregnol mediated effects. Now coming on to postpartum depression. Again, this is a period where you see a significant hormonal change. And affected women, they experience a depressive episode which might occur with anger and hostility towards infant. And especially in the first 4 weeks of childbirth, and mother-infant attachment is significantly impaired. This is a very important, postpartum depression is an area of great research because with significant impact, not only on the mother, but also on the baby. And if it's not treated, it can lead to suicide. And PPD, the pathophysiological, etiological factors which were implicated in PPD were, which I had already discussed, but I'll highlight again, the altered activity in amygdala, prefrontal cortex, cingulate cortex, and insula. Similarly, there are epigenetic factors, genetic factors implicated, and HPA axis abnormalities. And very, very important, neurosteroid, allopregnol derivative, Brexnol, now has been found to be a very successful molecule which is giving quick response in treatment of PPD. Now, there's so many potential pathophysiological factors, but now more or less it is becoming clear that neurosteroids, that is estrogen and progesterone, they all are interlinked with these other biological factors as well. So we have to understand all these in a holistic manner to come to a clear-cut, exact model of what are the pathophysiological etiopathogenetic factors leading to reproductive subtype of depression. Now, in PPD, there are family and twin studies which have indicated there is a genetic basis, especially genome-wide linkage and association studies have found variation in areas chromosome 1 and 9. And SNP studies have found potential involvement of 2 estrogen-responsive genes. And these candidate genes have implicated polymorphisms, which also are relevant to serotonin transporter gene and catechol O-methyl transferase gene and estrogen receptor alpha gene. So even the metabolism enzymes, they are having a genetic implication, are trying to make us understand that PPD may be a different biotype of disorder. So the one commonality across all these genetic studies is the issue of timing. The results are often positive when symptoms are measured close to delivery, which indicates that there is a genetic basis to PPD only when the timing is clearly linked to hormonal trigger of childbirth. So recent studies have also implicated epigenetic markers like
Ma'am, last 10 more minutes.
Yeah, I'll be able to wind up. So I'll be stopping at the etiopathogenesis part, and we'll keep the treatment part in discussion.
Thank you, ma'am.
So the two loci that have been identified are HP1, BP3, and TTC9B genes. There is substantial involvement that other than heritability, biological symptoms, especially the endocrine system, is also implicated, which I had already discussed, that there is a vulnerability to change in the hormones, and lower level of allopregnol and poor allopregnol response to stress has been associated with PPD. And FDA has approved the first drug for PPD, Brexnol, which acts much faster than SSRIs, which is a synthetic version of allopregnol, indicating that the neurosteroid system works in close concert with the HPA axis and is implicated. There are other hormones also implicated, but they're not as important. So I'm just leaving these out. But there are other symptoms to be implicated, which we need to understand. Due to paucity of time, I'm not going into each one of them. But all these have indicated to us that there are different biophenotypes. Now, neural activity in PPD, like I'd already mentioned, in PPD, I had shown you that diagram, that they did task-based functional MRI studies and found that amygdala, prefrontal cortex, cingulate cortex, and insula, they are mostly implicated in the pathogenesis of postpartum depression. So a lot of research. This is a beautiful article, which I would recommend you to read to understand which are the areas involved by Stickle et al. Now coming on to perimenopausal depression. Here, during perimenopause, again, the hormones fluctuate. And again, it is these that are responsible for increased risk of depression. So it is only during the perimenopausal phase, that is during the transition of fluctuation of the hormones, that the women experience depression rather than in the post-menopause. And it is during this period that hormonal treatment is effective, indicating that if you can correct the fluctuation and you can use estrogen or allopregnol or OCP to correct the fluctuations, the treatment is effective. So fluctuations are the ones which are the most responsible in perimenopause. In addition, fluctuation of FSH and luteinizing hormone relative to a woman's own mean level implicates a more chance that she will develop depressive symptoms during the perimenopause. So there are a lot of studies which have been found to prove this hypothesis, which I'm not due to paucity of discussing with you, but not only fluctuating estrogen levels, it is also the fluctuating progesterone levels that have been found to be implicated. So, and especially now current research in the perimenopause is also on the fluctuating level of allopregnol because of its ability to act on GABA A receptors. So those women who do not have GABA A receptor insensitivity or lesser number of GABA A receptors are present due to genetic vulnerability, then they might be more prone to perimenopausal depression. So this is regarding etiopathogenesis, indicating that there are different types of biotypes of depression. These are on hypothetical stage, I agree, but the current genetic evidence, the hormonal changes, do give us an indication that they deserve a separate nosological entity, and on basis of which we can develop different pharmacological interventions like using SSRIs and use the support of estrogen hormones as part of treatment. I will discuss the treatment part later in the discussion if Rukshida permits due to time limitation. If I can give me 5 minutes more, I will just talk on general principles of hormone therapy. Rukshida, you want me to do it later or I can do it right away?
Ma'am, if it's less than 5 minutes, yes, please go ahead.
Okay. So in using estrogen, transdermal estrogens are preferred because they have lesser side effects and they can be used as first choice therapy during the perimenopausal period. And postnatal depression also, you can use transdermal estrogens, patches can be used, gels can be used, but these are only in research. We don't have enough evidence base, but early studies are indicating that in addition to SSRIs, you may use them. I had already mentioned regarding the drugs that are used. SSRIs are doing much better in all three phases because of the etiopathogenesis that I had discussed. Compared to TCAs, SSRIs are more effective in all three phases of reproductive subtypes of depression. So to conclude, women are more prone to depression during reproductive years. Few women are vulnerable to hormonal fluctuation, and they constitute this distinct subgroup of reproductive depression. It is an important clinical subtype of MDD, and it may predict future clinical course during reproductive life events and may imply specific treatment options or algorithms. Having one type of reproductive depression may be predictive of experiencing other types of reproductive depression. Available evidence suggests that serotonergic drugs are more effective and hormonal treatments may be considered in refractory cases. And this is an interesting area of research. Thank you, Rukshita, for giving me to speak a little more than my time. Thank you.
Thank you so much, ma'am. I know that the topic is vast, and of course, we wanted to keep hearing you, but we also have a huge panel that we have with us, and we would definitely want to hear from them. And we sometimes learn more in Q&A than we kind of learn even in presentation. So we're hoping to get some more learning by sharing. With this, it's a pleasure for me to invite the moderator for the session today, Dr. Avinash D'Souza. Thank you so much, Avinash, for joining us. We all know Dr. Avinash. He's doing great clinical work and research work with so many publications and mentor to so many young scientists and researchers and people who want to publish as well. And of course, he's also the General Secretary of Indian Association of Private Psychiatry and a dear friend who's from my same city. So yeah, I would like to think there's something in the water in our city, isn't it? So with that, I'm going to request Dr. Avinash D'Souza for the moderator of the day to take over, please.
Yes. Well, am I audible?
Yes.
Okay. So we have 18 panelists, and we're going to start with one question each. The order I'll follow is the order on the poster. I think that's the best way to go, so I don't miss anyone out. And we keep the answers brief because we all have to wind up by 9:30. We can go on till 11 if we want, but we'll have to wind up by 9:30. It's a first ever, I think, seminar on reproductive depression. We've always had the subtypes discussed. It's the first time I'm moderating a panel of 18 leading female psychiatrists. I was very happy to see myself alone on the poster there. So without further ado, we start. My first question is to Madam Dr. Gauri Devi. Is Madam there? I'm not able to see all panelists on my screen. So is Madam there?
She was.
Yeah, I'm there.
Yes, ma'am. Good evening, ma'am. Madam is a consultant psychiatrist at Asha Hospital. She's one of the senior most members on our panel with over 40 years of experience. Ma'am, I have just two small queries for you based on your wisdom. One is that, what do you feel about the term reproductive depression? Do you think it's a good term, or do you feel, we're putting too much of hormonal influence when we use the word reproductive depression? And what do you think in your experience, you've seen the last 40 years of psychiatry. So what would you just like to share in 2 or 3 minutes about this?
Yeah, thank you, Avinash.
Yeah.
It's a great. Now, am I audible?
Yes, yes.
Yeah. Yeah, nice to be with all women who has been practicing psychiatry and more so like reproductive, the psychiatry more than me, because I'm a child psychiatrist, mostly spending time with the children. And of course, I see adults as well. Coming to the reproductive depression subtype. Yeah, I would say that the research, first I will talk about the research. The research indicates whatever changes which we see in the reproductive so-called subtype depression is similar to major depressive disorder. Except that, what Sonia has been telling about the insular area where it's a little more stimulated. I would like to put it other way around. Is it that these people who are vulnerable genetically for major depressive disorder, maybe a group of them are, sensitive to fluctuations in the hormones? That's one. The second important thing I would like to comment about the research is that none of them are really taken the men who are depressed, in the similar age group. I mean, they haven't studied the testosterone levels. Is it that there is something which is protective, the testosterone levels? So that's why I don't want to be totally carried away by, no, it is known that definitely they do have, this is more of an association rather than the cause and effect. That's one. The second thing I would like to tell is coming to the clinical experience, we have seen that most of these people, either depression, they develop around the puberty. That's one. And it disappears automatically without being treated. So that means there is a mechanism which helps them to really get over. It could be biopsychosocial. Then coming to PMDD again, I would say not all people develop PMDD, and I that there is always a group of people with a family history of either bipolar depression or depression. The congregation is seen. And another important thing clinically, I would say the people who had PMDD invariably, not all, invariably develop puerperal depression, I mean postpartum depression. And also these are the same group of people who are vulnerable for the menopausal. It's not that they quickly follow the same order, but this is one thing which I found in all the people whom I've seen. So what I say is one, genetic vulnerability. Maybe these are the people who have serotonergic deficiency. Maybe these are the people who are hypersensitive or sensitive to the fluctuations in the hormones. Okay. And so that's why they are really responsive to serotonergic medication. And having said that, I also have collaboration with the gynecologists. They always say, in spite of the hormonal thing, the mood symptoms, they don't disappear. Invariably, they ask the psychiatrist to put them on medication. Either it is during hormonal thing for IVF or depression, I mean, during pregnancy or postpartum. So this, I would like to say, I'm not really at this stage for the separate subtype of reproductive depression. It's either you take it because it's only association rather than, cause and effect. Thank you.
Right, ma'am. Thank you so much. My next question is to Dr. Shanti Nambi. Is madam here? Dr. Shanti Nambi?
While we, hopefully we can get Dr. Shanti Nambi back
yes.
again.
Yes. So I will move to Dr. Supriya Hegde. Madam is the professor and head of Department of Psychiatry at Father Muller Medical College, Mangalore. Well, my question is very straightforward, ma'am, that when it comes to a case of postpartum depression, what according to you is our drug of choice? And well, in psychiatry, ECT is of course a dying art and it's become an orphan. So do you think ECT still holds good in postpartum depression particularly?
Dr. Avinash, thank you for the questions. I'll be brief. So I use a lot of sertraline in postpartum depression. One of the reasons is because we are teaching in a PG institute. The secretion of sertraline into the breast milk is quite less, and a lot of women tolerate it well. So I use a lot of sertraline. It's not that I don't use the other SSRIs, but sertraline is my favorite. I have used up to 200 to 250 milligrams of sertraline. And even if it is the first episode of depression, that is postpartum, I treat it for at least a period of 6 to 9 months. Many of them are actually referred by the obstetricians early in the course, but still I give a full cycle of treatment. ECT, we have recently given to one of the postpartum ladies who also had psychotic symptoms and had a past history of response to ECT. So many a times the stigma around ECT prevents us from giving it more often. But surprisingly, it works very well. And we can actually reduce the number of drugs that we use if we give ECT in time.
Right. Thank you so much. My next question is to Dr. Sujata Sethi. Is madam here? No, okay. I will move to Dr. Anita Gautam. Well, madam is a psychiatrist at the Gautam Hospital and Research Center at Jaipur. My question to you, madam, is you see a lot of patients who may also have perimenopausal depression. So in such patients, what do you think is your first line of management? And particularly some of them may be on hormonal replacement therapy as well. So which drug from a psychiatry point of view would you like to sort of administer to them? You'll have to unmute yourself now.
Yeah.
Good evening, everybody. Yes, we got a lot of patients of perimenopausal syndrome, but usually we put them on the treatment, SSRI treatments, because most times hormonal therapy is not usually as a first line therapy nowadays. But as ma'am told, in future we will take this hormonal therapy as a first line if it is good, and usually they are not taking advice from the gynecologist. They are not on the hormonal treatment. They usually come with the symptoms of depression to us, and we treat them SSRI. So where first line treatment escitalopram, we keep them on escitalopram, SSRIs.
Right. Okay. My next question is Dr. K.S. Pavitra. She's a consultant psychiatrist from Shimoga, Karnataka. Well, what do you think are, probably the socio-cultural determinants of reproductive depression? Considering your interest in transcultural psychiatry.
Yeah, I think that's what actually defines how reproductive depression can be different from, depression otherwise. Because I feel though hormones have a major role in biologically in females, I think the socio-cultural determinants cannot be undermined, and actually they should take equal role in either directing our, guiding our management. Because see, finally, as most of the senior psychiatrists agreed, Dr. Gauri Devi or Dr. Sonia, then of course Supriya, everyone said that finally, if you call it reproductive depression or not, you're going to treat them with SSRIs or antidepressants or ECT. So actually, Dr. Gauri Devi pointed out very clearly that, just hormonal therapy is not going to suffice. So what makes it different, the management, is that, how much socio-cultural constructs are taken into consideration. So I think it's very, very important because take, for example, postpartum depression. The study from Nimhans has clearly shown that one of the important risk factors for postpartum depression in Indian mothers is one living female child already. So the second pregnancy, the mother is extremely anxious whether she's going to get a second child as male or female. So that also, has complex interactions biologically. So I think it is very important, and I think we should pay attention not only as psychiatrists, but here there are obstetricians, lot of other endocrinologists. All these people need to take into consideration those factors into consideration very much. Social origins of depression.
Right. My next question is Dr. Hina Merchant Pandit. She is an associate professor at the Department of Psychiatry, Lokmanya Tilak Hospital. Works with me at that department. Well, we work in a tertiary general hospital, and do you think and we have one of the busiest gynec units, obstetrics units in the city. So do you think patients coming there, are aware of postpartum depression? And secondly, do you think we should screen every woman coming there in the third trimester for postpartum depression so that probably we could keep a check and prevent it in the bud before it starts?
Hi, good evening, everyone. Thanks, Avinash. I think as you very rightly pointed out, yes, we at Sion Hospital are actually catering to a very large area in Mumbai, which is Dharavi. So yes, we have a lot of deliveries, and my observation since the time that I have joined Sion is that they are not at all psychoeducated about depression at all. I don't think many a times they are even psychoeducated about pregnancy. They don't even know what they're supposed to be doing in pregnancy, right from, what they should be eating, what they should be doing, how they should be taking care and all. So I think depression, I think psychiatry really takes quite a lot of a backseat here. So I think it's very, very important that, yes, there has to be a multidisciplinary team approach, that there should be a gynecologist, there should be a psychiatrist, and especially in those women who have already had a past history of depression, or they have symptoms of a bipolar mood disorder. It is important to have them screened and intervention provided to them at the earliest. But unfortunately, such a thing really doesn't happen at our tertiary care centers.
Right. Thank you. My next question is Dr. Diptisha Gada. She is a consultant psychiatrist who runs her own center called the Grooming Minds in Ghatkopar in Mumbai. Well, since you deal with a lot of children and adolescents, my question to you here is that we see a lot of adolescent girls in our practice with depression. And my question is primarily directed at children and adolescents who are in 8th, 9th, 10th, 11th or 12th standard, where probably the hormonal development is not yet complete. So we see a lot of hormonal fluctuations. Now, as it is, parents are very reluctant to start medication, but we exhort them to start medication. So one is, what do you think over the years, has been your favorite drug of choice for depression in adolescent depression primarily, and particularly because we don't want them drowsy, we want them to study, we want them to do everything. So keeping that in mind.
Yeah, so obviously, even amongst adolescents, SSRIs is always the primary drug of choice. We use fluoxetine as the commonest medicine for adolescent depression. But I think, as Dr. Pavitra also mentioned, and we understand that, adolescence is again a huge area where there's a lot of identity formation happening, socio-cultural influences. So most of the children who come to me, we do ensure that they are also undergoing some counseling sessions with a counselor. The therapist is able to provide them with certain, therapeutic techniques to help them with their emotional issues. They may be going through a lot of other issues which are also, contributing to their symptoms. Maybe their issues with parents, their issues with academics, their issues with the opposite sex, their own cultural, their own identity formation. So I think a supportive psychotherapy, sometimes with the parents, family therapy, all these also play an important role along with medication. Medication probably also has a more supportive role in conjunction with other therapies.
Just since we're on this, few tips of advice, what would you tell teachers to handle these children in the classroom?
I think the first thing is that the teachers need to be sensitive to the changes which the adolescents are going through. Teachers need to spend a little time with each of these students individually in order to understand their psyche. If they find that there are some behavior issues, there are some children who are, kind of mischief mongers, or they're creating more trouble in the class. If some child is not doing well academically, that also the teachers need to spend a little time. They should also ensure that most of the schools these days, at least in the metro cities, have counselors. So spend some time with the counselors, learn and understand what these children are going through. So having that kind of a thing, I think a lot of schools also have slowly now started like a mentorship program where, there are other students who kind of become mentors for these younger children. So that kind of program is something the teachers can probably ensure that is happening in the school. So understanding the mental health of adolescents by the teachers, I think, is extremely important. And we also try to psychoeducate teachers by taking sessions for them and making them understand what are the hormonal changes, the mental changes which the adolescents go through during this period and how the teachers can manage.
Right. Thank you. Dipti, my next question is to Dr. Sugandha Gupta, who's from Delhi. She's from the consultant psychiatrist at the Mind Clinic in Delhi. The question here is that many women undergo hysterectomy, and some of them, of course, have this feeling of an organ loss. The womb is lost, particularly post-hysterectomy. So any specific tips on the management of depression in such women? You'll have to unmute yourself.
Thank you, Dr. Avinash. That's a nice question. I think it moves a little away from the topics that we've been discussing up till now. So like you rightly said, hysterectomy is a pretty life-changing event for any woman, whatever the reason might be, and definitely comes with its own set of emotional and social and other kinds of trauma. So leaving aside the biological involvement, what needs to be done is, first of all, psychoeducation of the patient as well as the immediate family members, the life partner. Mostly it is taken away as, any minor surgery or anything just had to happen. And not enough importance is given to the emotional well-being of the female at this time. So sometimes females also themselves do not kind of understand how this event would have deeply moved them. What are the things that they are themselves facing, insecurity about their gender, about their future, about their life ahead, leave aside the intimate relationships with the partner, doubting the intimacy and the trust and their availability and need in the life of the partner. There would be many other factors. But most importantly, psychoeducating the lady, first of all, that this is an important event and it will have its own implications. And then the life partner, helping them in their relationship remains the primary goal of such treatment, And it definitely should be treated biologically or medically as well, if required for some time, to allay anxiety and if there are syndromal depressive symptoms too.
Fine. Thank you so much. I now move to Dr. Shivani Deshwal, who's from Kethal, and she's a consultant psychiatrist at the M&K Hospital. Well, in your practice, ma'am, when you see patients with reproductive depression, what are the other, do you see a lot of somatization and other psychosomatic conditions with it? And if you do, then what are they and how would be our approach in those cases?
Thank you for the question, sir. Yes, with the reproductive depression, there are somatic concerns that need to be dealt. So I would share my experience of North India, and usually the young girls come to the clinic and they report somatic complaints like lack of concentration and somatic pains. And usually what I explored about the vaginal discharges. So I am sharing my recent experience. So usually when they come with anxiety, depressive symptoms, so they have the concerns about the vaginal discharge and about the amount of blood loss during menstruation. So usually they are preoccupied with the things like we see in heart syndrome, that due to vaginal discharge, they're having depressive symptoms, anxiety symptoms, and somatic complaints. They attribute the somatic complaints to the vaginal discharge or to the blood loss, to the menstruation. And most of the times they have already consulted gynecologists multiple times and not cured. So only psychoeducating the family and the females help a lot with these females and improving their nutrition. So this is how I deal. And obviously, whenever needed, I start the anti-anxiety and antidepressive things, drugs.
Right. My next question is Dr. Amandeep Tori, who's from Varanasi, and Madam is a psychiatrist at the City Neurology Hospital. She also runs Smarthan, which is a group for autistic and neurodiverse individuals, along with Atmanthan, which is a teacher psychoeducation group. In management of reproductive depression, particularly, what do you think? We've all spoken about SSRIs, but do you see any role for SNRIs, mirtazapine, vertioxetine, vilazodone, these newer drugs? Do you see any role for them? Your opinion?
Thank you, Dr. Avinash. Yes, sir. SSRIs, mostly postmenopausal depression, SSRIs, I see.
No, SNRIs, ma'am.
SNRIs in postmenopausal depression has proven to have more effects, especially somatic effects. So I choose SNRI over SSRIs specifically in postmenopausal depressions.
Okay.
Otherwise, it's symptom-based for sleep. If they have sleep issues more, then I can use mirtazapine. So I prefer mirtazapine, SNRIs for postmenopausal depression. And for younger generation, usually if there are depressive symptoms, then I prefer SSRIs.
Since you work with individuals who are neurodiverse, I'm just mentioning this because it was part of your introduction, and they may not be very expressive and you may not understand that they're going through depression. But if I'm talking about women who are having developmental disabilities and are neurodiverse, how do you identify reproductive depression in these cases? I mean, based on your experience.
A lot of, I'm actually running a support group for parents. So specifically, I see mothers and I do counseling sessions with them. I keep a check on if they have, if they go from mild to moderate depression. In a lot of cases, I usually do counselings. I do CBTs, and if I feel it's going towards severe depression, then I give them a course of antidepressants.
Okay, ma'am. Thank you. Our next question goes to Dr. Neha Bhave Salankar. Is Neha here? Yes.
Yes, sir.
From Nagpur, from the Bhave Institute of Mental Health. Well, my question to you is very direct. What psychotherapeutic approaches, do you think would work in cases of reproductive depression? CBT, everyone speaks of. I mean, of course, you'll also mention the same, but generally, if I had to say a general psychotherapy paradigm, what would be your approach?
Right. So, first of all, it's a pleasure to be a part of this star-studded platform, and thank you for the question. I think the first thing which everybody can do without a lot of time being invested and structured sessions being done is psychoeducating the patients about why these symptoms are happening, especially when it comes to PMS symptoms or postmenopausal symptoms, because a lot of times you don't understand the biology behind it, about the kind of hormonal fluctuations that are occurring in the body. So I think the easiest first thing to start with is psychoeducating the client about why these changes are happening. Like you said, of course, CBT helps, but I think then working on their interpersonal issues, a lot of times support from the family is missing, and that leads to an increase in their frustration and irritability and a sense of being alone. So if we if we are seeing any specific interpersonal problems, then maybe our work could involve interpersonal therapy or family therapy. If we see any background issues that are happening that are triggering these symptoms, a lot of times females who are undergoing postpartum depression, we come across socio-cultural issues also, like speakers previously mentioned about maybe they had a girl child instead of a male child, or they are not able to breastfeed as well as they expected, and in such a scenario then the social support, family mobilization becomes important. So working with the family, with family therapy. So I think apart from core CBT principles, these other things which enhance support for the woman who's suffering from these things become very important. Group therapy, we encourage females to join support groups. They could be offline support groups, or they could be online fora where they can speak to people who are suffering from problems similar to theirs, and those kind of things.
My next question is Dr. Mansi Gora. She's consultant psychiatrist at the Project Mind Clinic in Mumbai. Well, my question here is two. One is that if a patient comes to you with depression in the reproductive age group, as a psychiatrist, apart from getting routine investigations done, you also get hormonal assessments done. And of course, then you would refer if there are abnormalities. And second, it's an audience question, but I'll just put it to you. If you have patients in this reproductive period with improvement in depression, but insomnia persists, then what would be your drug of choice?
Right. So I didn't get the first question. You said
the first question was, if the patient comes in with reproductive depression, they've not been to a gynac before, in your routine investigations, would you also get hormonal tests done or no? Or, would you get it done and refer, or not get it done, leave it to the gynac? What would be your approach?
Yeah. So generally, what I do is I get their basic profile, like you said. I always prefer to do thyroid tests with them. Sometimes if I feel that they're not responding to treatment, then maybe I get the LH, FSH profile done, and then I send them. But because I work in close liaison with endocrinologists as well as gynecologists, of late I prefer to send them directly to those people so that they can do because I would read the findings and that's it ends over there for me, right? So I prefer to send it to them, but definitely advisable to do those tests sometimes, especially if they are not responding to the routine therapy. And the second question was if they are still having insomnia. So of course, the reproductive depression, even in that, let's say if you have someone who's having a postpartum depression, then she would have to stay up to feed the baby. She would have to stay up to make sure at least wake up a few times. So the drug of choice there would be something else. For someone who's having a perimenopausal depression, it would be something else. So something like desvenlafaxine would be my drug of choice. If the mother is in the weaning period, if the mother is in the initial phase, I would maybe add a low dose of mirtazapine where she's still breastfeeding the child. If it is a perimenopausal female or a postmenopausal female, I've seen that they come with a lot of somatic complaints. And for some a lot of times they have gastric intolerance, they have gastrointestinal issues. In such cases, mirtazapine definitely works wonders. So depending on their age group, depending on the roles they're playing in their life, where, how much of sleep are they actually able to get and how much of sleep can they afford to get, I would go for one of these drugs. And if I feel it as a transitional period where a short-term sleep disturbance is seen, then my drug of choice is Dayvigo for sleep disturbances. Is really good, works for a short time, easy to taper it off. So yeah, it would depend on the phase she has come to me in.
Okay. My next question is Dr. Mansi Jain. She's a consultant psychiatrist at Manorogya Clinic in Mumbai. Well, Mansi, my question here is that when you get patients with premenstrual dysphoric disorder or PMS, Do you believe in treating, one is what would be your drug of choice? Second, would you treat month long, or do you prefer starting treatment 1 week prior to the cycle and then stopping it once the bleeding stops? What is your general approach?
So the go-to drug is usually an SSRI in these cases because most of them are presenting in the adolescent or young adult age group. Again, the treatment duration varies with patient to patient. Sometimes they benefit with a short cycle just around their menstrual period. But like, we discussed that the speaker also mentioned that some of them will have a depressive episode which gets kind of triggered by hormonal fluctuation. In such cases, depending upon how much disability the depressive symptoms are causing, sometimes we even decide to treat month long. Sometimes I've seen using vitamin E and using other, sometimes even giving them a cycle with the oral contraceptives, which is recommended by the gynecologist, kind of helps with their mood symptoms. So I do liaison with a gynecologist as to with regards to know what they can do from their end of the treatment. SSRIs from my end are the go-to drug, and definitely the treatment timing would depend from case to case. But yes, in most cases we do treat them month long, and in few cases where the symptoms are very mild, treating only around the cycle does kind of help. Thank you.
My next question is Dr. Iska Sinha from the Indira Gandhi Institute of Medical Sciences, Patna. Well, when you see a patient with depression and particularly having a lot of gynecological comorbidities like endometriosis or dysfunctional uterine bleeding, or for that matter, heavy bleeding during their periods or whatever. Now, in such cases, what is your drug of choice? Because we've been very often taught that someone who's bleeding, we don't give an SSRI, or we don't probably, we'll be cautious when we're giving SSRI. So what would be your take in managing depression in these patients?
Thank you for having me in this panel. It feels lovely connecting and learning and seeing a single male person moderating so many of us, many of all the females. First of all, I would say it's a phase where a woman is supposed to be, one has to be, it is thought that she has to be overjoyed. It's a phase where, and when you find yourself landing up in such a dark room, you're not, you are finding everything is not going right. So many physiological changes, hormonal changes in your body, your bodily changes, and even your social role. So with that, you are struggling, and then you have to smile, and you are not supposed to complain anything, because it is a phase which is motherhood is a blessed phase where you have to be very confident, be very happy, and so that we need to be very careful. What question, Dr. Avinash, so you were asking is whenever we have such comorbidities, I would always like to treat that patient in liaison with the gynecology department of my institute, and very often I prefer to give low dose antipsychotics like olanzapine. I have found it to work wonders, because these patients, they have sleep problems, they have mood problems, and many times we miss the subtle, the soft bipolarity in these patients. We think we are dealing with a patient because reproductive depression has many atypical presentations, irritability and those things. So it gets controlled when we give low dose olanzapine. So I give it quite often.
Any role for aripiprazole?
Aripipra, yeah, it's just on the safer side, but when it considers when you want mood, when you want sleep, when you want everything to be on the balanced side, low dose HS dose of olanzapine works wonders. In few patients I've tried aripiprazole, but maybe restlessness and those akathisia, it increases, so I don't prefer it so often.
Yes. We'll now move to our last three panelists who've been waiting very patiently. Just for your information, we have 681 people in the viewer link, 100 people seeing us live on YouTube. So we have 781 people seeing us. Though we are able to see only 18 or 20 of us, there are 781 others who are viewing us. My next question is to Dr. Dipti Bhatt, who is from the Hospital for Mental Health, Ahmedabad. Well, ma'am, my question to you is two. One is, if you have a lady with depression who's a working woman and particularly has to be active the whole day, what would be our drug of choice? Because they cannot have any amount of sedation. Let's say she's working in a corporate sector, she's at a CEO high level, and she needs to be active and alert. One is, what would be our choice of drug? And what do you think, how much does marital issues play a role also in reproductive depression?
Oh, first of all, thank you, Rukshita, for this wonderful event. And it was an academic feast to listen to Dr. Sonia. And am I audible?
Yes, yes.
Yeah. So moving towards the first question, we do see a lot of working women coming with these kinds of issues, and it is very difficult for them to manage the gynecological symptoms and over and above that, the psychological symptoms. My drug of choice is again SSRIs because they are less causing sedation. They are women-friendly antidepressants as they are called. But even with sertraline, I will also prefer escitalopram in this women, and I'll give them a choice. If they want, they can take it at night. Usually we do give it in the morning, but we can give them at night if they want. So they don't have to take it at workplace or something like that. So that's the first answer. And yes, a lot of marital issues play a lot of role in those the symptomatology. Like they can be the cause of the stress. They can be the part of the presentation. They come with the symptoms. So in those cases, psychoeducation and interpersonal therapy, as one of the panelists suggested before, would help the most, as I think. Thank you.
Ma'am, my question is now to Dr. Kanak Gilurkar Sharma, who's from Nagpur, and she's from the Mind Over Matter Clinic over there. In case of reproductive depression, I mean, what all would you like to educate the family about? What are the things that you would want to, tell them?
Thank you so much, sir, for the question. I have been closely following yours and Rukshita ma'am's lectures since I was a resident. So this is a wow moment for me right now, being on the other side and speaking to you as a
moment for us.
So of late, what has happened is I have been liaising with an IVF specialist, and there have been so many women who have been having difficulty with conceiving, and because of that, somehow it's a vicious cycle, like the mental health leading to the difficulty in conceiving and vice versa. And a lot of time they are very reluctant to take medications because they're already on so many hormonal injectables that they are very, very reluctant. So I have to, first of all, psychoeducate them a lot, the women and the husband as well, because a lot of those times women don't have much of a say even for their bodies, and so I have to sit with them, have couple therapy with them, often have family and group discussions, and give them examples of other patients. So this is my first line of management rather than actually jumping to a drug. And then later on, even if that is possible and with some amount of therapy and even venting out helps for them. And beyond that, if still the severity of their condition is not helping them cope up with it, then I would actually go ahead and add on sertraline and low dose of olanzapine for that matter. Like ma'am said, yes, I have tried 1.25 and 2.5 olanzapine, and it has helped very well.
Okay. My next question is Dr. Chami Shah, who's from the Divine Psychiatry Clinic in Ahmedabad. Well, ma'am, we very often have patients who we treat, and then they go to their gynec and endocrinologist, and they are misguided about our medications that, don't take this, don't take that, and, this will happen and that will happen. So what do you think, I mean, we as psychiatrists can do to, educate gynecologists and endocrinologists about it? Because very often the main problem which is endemic is these three specialties don't talk too much to each other. So what do you think we could do in this regard?
First of all, thanks to the esteemed speakers and the panelists for this wonderful discussion going on. And sir, you have raised a very important topic that other specialties, they already have misconceptions for our drugs, and they spread that misconception to the patients too. So I'll recommend that we should often organize some meetings and some even friendly discussion also with those specialties, particularly the endocrinologists and the gynecologists, about the drugs, that always the psychiatric drugs are not the misnomers for everything. And we should even educate the patients too, that the medications, if another doctor is saying that you should not take the medicine, they should also ask to the treating psychiatrist also for discussing those things. So discussion with the another licensing fraternity is very important, so that this misconception about the drugs get lower.
Right. Well, is Dr. Shanti Nambi and Sujata Sethi here, or they haven't joined us because they were the only two people who I have not asked questions to?
They were here earlier, but I think there's some connection issue,
Okay.
so I don't think
Right.
they'll be able to
So,
join us now.
what I propose is that now I'm going to run a very fast rapid fire for our people who are here. I'm going to give you a condition and you just give me the drug of choice. No explanations why, what. You just give me the drug of choice. So we'll run through that. And then after that, there's one question which I want to answer, which has come in from the audience. And then I'll hand it over to Dr. Pariyal and Rukshita to take it forward from there. So we'll start with Madam Gauri Devi. I'm deviating a little, but Madam Gauri, in a patient having depression at the age of 65, your drug of choice?
Yeah, I prefer metrazapine.
Okay.
Yeah.
Fine. Thank you. Dr. Supriya Hegde, patient having depression with hyperthyroidism, your drug of choice?
Sertraline.
Sertraline. Okay.
Also escitalopram.
Okay. Fine.
I ride escitalopram much more than I ride sertraline. But any organic condition, better to give drugs which have least interaction.
Right. Dr. Anita Gautam, PCOD with depression, your drug of choice?
Yeah, escitalopram.
Okay. Dr. Pavitra, are you there?
Yes, I'm here.
Okay.
Sure,
Yeah. Okay. So, 12-year-old who hasn't attained puberty, drug of choice for depression?
Escitalopram, 5 mg. Yeah.
Okay. Hina Merchant, lady who's breastfeeding, drug of choice for management of depression. You're muted. You'll have to unmute.
Sertraline.
Okay. Diptisha Gada, 10 standard, 12 standard student brought to you with exam anxiety in February, exam in March, drug of choice?
Combination of escitalopram with propranolol.
Okay. Dr. Sugandha Gupta, drug of choice in a lady with heart disease and depression?
Sertraline for sure.
Okay. Dr. Shivani Deshwal, drug of choice in a patient having a gynecological cancer and depression?
So metrazapine, because of less interactions.
Okay. Dr. Amandeep Puri, if you have a patient of epilepsy and depression, your drug of choice?
The escitalopram.
Okay. Dr. Neha Bhave, a patient having a lot of acidity, gastroesophageal reflux disease and depression, your drug of choice?
I'll probably go with a TCA like nortriptyline, because in my experience, it has a good effect on somatic component of these GERD symptoms also. Or then maybe something like metazapine, if there's associated loss of appetite, weight loss, then even metazapine works well.
Mansi Vora, reproductive depression with bronchial asthma, your drug of choice?
Escitalopram.
Okay. Mansi Jain, drug of choice for patient with reproductive depression and irritable bowel syndrome?
Sorry, can you repeat that?
Drug of choice for a patient with reproductive depression and irritable bowel syndrome?
So SSRIs with low dose of antipsychotic, second generation antipsychotic.
Okay. Niska Sinha, your drug of choice for a patient having tuberculosis and reproductive depression? Since you work in a hospital setting, you may see patients like that.
And go with escitalopram.
Okay. Dr. Dipti Bhatt, your drug of choice for a patient having depression and raised prolactin, which is not due to psychiatric causes?
probably SNRIs.
Okay. Dr. Kanak, your drug of choice for a young girl who's just attained puberty, say 13, 14 years old, and depression.
I would actually go with low dose lithium and SSRIs. I'll combine them.
Okay. And finally, Dr. Chamisha, your drug of choice for a patient that has any Parkinson's at a young age, reproductive age group, and depression. Sorry, I gave you the tough one. You were the last one left.
Escitalopram.
Okay. So I think
I'm going to ask you your drug of choice in a reproductive age group woman with depression and sexual dysfunctions.
Well, I would preferably then start with mirtazapine. I mean, I think because that would work better, bupropion. I mean, this would be my thinking, you know, in that regard. I would avoid the SSRI, SNRI, anything. So that's there. Well,
I'm feeling left out because nobody asked me anything and I'm only speaking.
You're the chief over here. So, you know,
but I can still have 4 more, can't I?
Yeah. No. So anyway, now the thing is, there's one question which has been asked by Sumbul Siddiqui, and I'm going to just answer that. She's asked, there's a lot of interest in neurosteroids in depression. Madam has mentioned about brexanolone. She said zuranolone is another neurosteroid that's being tried out. Well, what do we feel about it? The answer is that zuranolone is in the process of trials. Drowsiness, fever, weight gain are a lot of its side effects. So it's not tried, not yet been approved. She's also spoken about ganaxolone. Now, ganaxolone is an anti-epileptic. It's a cycline kinase anti-epileptic, which is specifically developed for a genetic condition. And it's been tried in catamenial epilepsy, that is menstrual-related epilepsy, but it has not shown much benefit. And neurosteroids have to be a little careful because it can even flare up psychiatric conditions. So that would be my take. I will now hand over to Rukshita, and there are no more questions. I'll hand from the audience. I'll hand over to Rukshita. She can say whatever she likes before she ends, and to Dr. Sonia to end the session. Thank you from my side. Yeah.
Thank you, Avinash. Can I request everybody to switch on their video for like 5 seconds so I can get a screenshot with everybody on? Because now even Dr. Sonia Paryal switched on her video. So if we can see all of our illuminated and illuminating panelists here, that would make a great screenshot. And if I can ask one of the hosts to take a screenshot of the same. Pavitra, Shivani, if I can ask you to join in. Amandeep, if I could ask you to join in.
Ankit, just take a photograph, please.
Yes, sir. Yes, sir. Yes, sir.
And send it on the group for everyone.
Yes, yes. 1 second. Yes.
Yeah, Pavitra, we're not able to see you.
No, 1 second. I'll just come.
We are jealous.
Done.
Photos
Done
looking better than all of ours.
Should I take it one more
No,
time?
wait. Dr. Pavitra is coming. Dr. Amandeep is not there. Amandeep.
Yes.
Yeah, Dr. Amandeep. She's the only one who's not there. Anyway, fine. Okay, take it.
Okay. Smile. Okay, thank you. Thanks a lot.
Thank you. Thank you so much. Now that all of us are here, I know I promised a few seconds, but if you all could be here for a little longer, so Dr. Sonia Paryal can address all of you all. Dr. Paryal, last few clinical pearls and words of wisdom from your side, maybe encapsulating everything that you've said and some of it, some of what the panelists have shared.
I think, Rukshita, out of all the questions that Dr. D'Souza raised regarding treatment, we came about with a general conclusion that as psychiatrists, we all are using primarily SSRIs in the treatment. My question to you all is, today's talk was planned with what, keeping in mind what is reproductive depression different in any way from major depressive disorder? That's why I have focused a lot on etiopathogenesis. The obstetricians and the endocrinologists, from their perspective, I'll put a point across for us to start thinking when to liaison with them. In which conditions would you be liaisoning with them? It is a thought process to think. And this will become more clearer when we understand the etiopathogenesis of these disorders better. You know, all of us face in clinical practice certain patients who have PMS, but they're not, they reach to us only in severe stage. The mild ones, they are neglected. And the ones, and most of them go to the gynecologist first. And they have been using OCPs left and right, and with some success, with some not success, and then referring in the severe stage. So this is the area of research. Would there be some, for us to have guidelines, would you be using SSRIs in PMDD for a short time or a long time? Would you be using it only during the cycles? Would you be using somebody's history with only PMS with no other episode? Would you continue it throughout the month? This was a question raised by someone. These are questions yet to be answered clearly. Why? Because we are still in the nascent stage of understanding the exact model of reproductive subtype depression, if it exists. Brexanol acts very fast, quick result, it says. They say in PMDD, SSRI, you give it for a short time, very quick response, improvement is fast, recovers fully after menses. These are clues for which designer psychopharmacology, as I call. Maybe later on you'll have research giving us many more markers to help us decide how long do you use a drug, what type of drug to use, and whether you will use hormones in addition to the psychotropic drugs or not. You have resistant cases. You see, when this thought about picregitol came, the endocrinologists who felt that it is not just SSRIs, you might require hormones, was when they found certain cases don't respond to psychotropics. You're giving in every cycle. Yes, there is a subset of population. And if you add transdermal estrogen, the dose of the medication required is much lesser. Jayashree Kulkarni has some seminal work on schizophrenia, where psychotropic dose required was much lesser if she added transdermal estrogen. So these are areas of research giving us new thinking processes. So I wanted through this talk that we start thinking in other directions as well. The knowledge that we have about SSRIs, SNRIs is well established. No doubt, they are effective. But we also need to understand that the hormones play a significant, they interact a lot, with your drugs. So we need to go more into research. And I think in the coming decade, you will have more markers, more type of drugs, ideas that which you will use ketamine and whom you will use Brexanol, whom you will use only SSRI or SNRI. You will have better answers when we know the etiopathogenesis better.
Thank you so much, ma'am. Ma'am, one last question that we have from the audience is that Dr. Shivani wants to know if there is a role of testosterone in reproductive depression.
Yes, there are some studies, especially in women who are having decreased libido. Testosterone has been found to be effective. Some isolated studies I have come across where low dose testosterone has been used in reproductive depression, especially the ones who are reporting decreased libido.
Thank you, ma'am. I think we are quite in time now. So thank you so much for all the panelists. And, Sonia, ma'am, she's always so when she's doing a talk, it's something that all of us are very upset if we miss it. Yes, there's so much more to learn from ma'am, especially how to keep the thinking cap on and how to look at new directions for more answers. If we are asked the right questions, we might get the right answers. With that, I'm going to take this opportunity again to thank my moderator for the day, Dr. Avinash. You did an excellent job. And thank you so much. And all the panelists, they've been not only just attentive from the day one, from the minute of the session started, but have been enthusiastic about participating and answering and even asking questions. Our delegates, which I've been told that we've had an amazing number of 600 views for our session that is going on today, and a lot of people who also joined in.
We've crossed 800 now. That's what
we've crossed 800. So that I think goes to show the interest that is in women's health and women's mental health in general, I always say there's no health without women's mental health, and I've been told not to say that, but I'm still going to stand by it. With that, I'm going to thank everybody, and I'm no longer going to stand in the way between dinner and everybody else. Thank you very much for a very enthusiastic and a very energetic discussion. I hope to see you guys again in a couple of months when we have the second episode in this ongoing curated series. expertise with equal enthusiasm and appreciation. So thank you very much. I bid you all of you all a very good night.
Thank you so much, ma'am. Good night. Good night, ma'am. Good night,
madam.
sir.
Good night. Thank you so much.
Good night. Good night.
Good night. Thanks a lot.
Thanks for having us. Bye-bye.
Thank you.
Night, everybody. Thank
Good
you.
night. Good night, madam.
Thank you.
Thank you, ma'am. Thanks a lot.
Thank you, madam. Thank you. Thank you very much. Thank you.
Thanks. Bye. Mr. D'Souza, I thought initially you guys would come.
Just a minute.
That's okay. I'll speak to you later. No problem.
Okay, ma'am.
Yeah, I'll just call you I'll just call you now.
Okay, fine. Okay. Yeah.